Hello everybody, we're going to talk about neuropathies, which is a very common presentation. The nerves can be involved singly, multiply, all in multiple ways in the body, and this can be a very common presentation both in primary and secondary care. It can present with a dysfunction of the nerves. Basically, pathy means unwell, and so neuropathy means nerves that are dysfunctional. It can be either motor, sensory, or autonomic, and the nerves are generally motor nerves, sensory nerves, or autonomic nerves. They can be involved either together or singly. Neuropathies can be acute, as in the GV syndrome, or they can be chronic. Most neuropathies are chronic or subacute. Acute neuropathies are fairly rare. They can also be classified as sensory, as mentioned, motor, autonomic, or mixed. More importantly, they can be either demyelinating, which is the myelin, which is the covering of the nerve, gets involved and in a way peels off either almost completely or in patchy bits, and this is usually a secondary to an immune insult, as in the GV syndrome. Or it can be an axonal neuropathy, which is basically the axon of the nerve itself gets damaged due to various conditions. Now, neuropathies based on the pattern can be peripheral neuropathies, which is generally a symmetrical neuropathy in the classical 𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂 disturbition, or it can be a mononeuropathy, which is involving a single nerve. Commonest ones that you may come across in your practice are someone presenting with an acute foot drop, secondly to a tightly fitting plaster, or sitting cross-legged, and the common peroneal nerve is the one that's affected. Or it can be an entrapment neuropathy, such as the median nerve at the wrist or the ulnar nerve at the elbow. And finally, you can have a pattern called the mononeuritis multiplex, in which simultaneous or contiguous in multiple nerves are involved in various sites, but they are not continuous nerves, and can follow a fairly patchy pattern. Hansen's disease or leprosy was one of the commonest causes of mononeuritis multiplex, but you could get to see this in vasculitis as well. Now, peripheral neuropathy can be a mononeuropathy, and we spoke about median neuropathy, which is basically manifesting with the involvement of a single nerve, and will cause problems in the distribution of that nerve. This is mostly due to entrapment, but trauma also, such as the sciatic nerve getting involved in a gunshot wound. The commonest entrapment is the carpal tunnel syndrome, where the median nerve is trapped at the wrist in the carpal tunnel, and there is a band of tissue that sometimes can become fairly tight and thickened due to various underlying conditions such as rheumatoid arthritis, pregnancy, etc. And it can manifest as a very painful hand in the distribution of the median nerve. Trauma can also be one of the causes of this, and it presents with painful paresthesias, mostly nocturnal, in the distribution of the median nerve. But these paresthesias can also cause the patient to try and flick his fingers and try and get rid of these sensations, and they usually do not disappear despite all these efforts. And one of the ways to elicit this is the Tinel sign, where you take a reflex hammer and tap along the length of the nerve, or the Fallon sign, where you make a tight fist, and if you forcibly flex it towards the forearm and hold it there, then the symptoms will become manifest. Ultimate diagnosis obviously is by electrodiagnostic studies, nerve conductions, and EMGs, and you can pinpoint. This is most useful if you're planning to go in for interventions such as surgery. It helps the surgeons to make up their minds. The hand surgeons will look at the nerve conduction study reports, and likewise in the ulnar neuropathies, where you can exactly pinpoint where the nerve is involved. In a foot drop, the problem could be in the spine, it could be in the sciatic nerve, it could be in the common peroneal nerve, so the EMG studies help to pinpoint where exactly the problem is. Treatment is usually conservative. You can try steroid injections, you can try a wrist splint, particularly at night, but ultimately if it's painful and persistent and it's worsening, especially the electrodiagnostic parameters, then you might need to in such patients and snip the transverse ligament to free up the nerve. Ulnar neuropathy, on the other hand, is less common than median neuropathy. It usually happens in the cubital tunnel. Sometimes the ulnar nerve may enlarge in various conditions such as Hansen's disease, and then becomes more prone to pressure. But otherwise, it's usually subcutaneous tissues that will trap the ulnar nerve. Presents with painful paresthesia in the ulnar nerve distribution. So the lateral 2.5 fingers mainly for the median nerve, and the medial 1.5 fingers subserve the ulnar nerve. Also, most of the flexor group of muscles of the hand are supplied by the ulnar nerve, so ulnar nerve lesion not treated can lead to clawing of the hand. Treatment is usually surgical. Likewise, like median neuropathies, you have to free the nerve so that it can function. Radial neuropathy, on the other hand, is much rarer. It's usually found secondary to acute traumas. You can get it when you have a fracture of the humerus. Also, the famous Saturday night palsy, where someone may present with acute wrist drop after going to sleep with his arm hanging on a chair. Patients will present with a wrist drop, paresthesia in the back of the hand, usually a little U-shaped region between the thumb and the index finger on the dorsal aspect of the hand is the cutaneous supply of the radial nerve. Treatment is confirmed by electrodiagnostic studies, usually physiotherapy, splints. Sometimes if the symptoms are pretty bad and the wrist drop is not improving, you can try a tendon transplant procedure if the patient is not improved. Now, I've talked about mononeuritis multiplex. It involves simultaneous or sequential involvement of two or more non-contiguous nerves. Mostly a group of symptoms, can be acute, subacute, chronic, and can be sensory, motor, or mixed. Presents as an asymmetric neuropathy, but can later on become completely symmetric. It's very painful. Usually it's a single nerve, but yes, multiple nerves can be involved, and electrodiagnostic studies will confirm it. There are underlying conditions like diabetes, vasculitis, connective tissue disorders, but infections as well, especially leprosy and Lyme's, are also responsible for this. Treatment is of the underlying cause, and sometimes there may not be any effective treatment for this. Now coming to the well-known peripheral neuropathy, which is usually symmetrical, glove and stocking in distribution. Usually the numbness will ascend up to the level of the knee before the hands start getting affected. It can be sensory, motor, or mixed. It also can be demyelinating or axonal, depending on what the electrodiagnostic studies show. Diagnosis is clinical. There is a distal weakness rather than proximal. Proximal muscle weakness is more common of muscle disease. So the patient will walk with a high steppage gait, sometimes with a foot slapping gait, because there could be bilateral foot drops or certainly weakness of the dorsiflexors of the foot. There could be wasting, there could be trophic changes, color changes in the feet, the nails, and the loss of hair, and of course there would be a distal weakness, which can ascend proximally also, and ultimately can become a symmetric weakness. Moves from distal to central, lower limbs followed by upper limbs. Usually once the level of numbness and paresthesia has reached the knee, then the fingertips start getting affected. Common causes could be metabolic, mainly diabetes and other metabolic diseases, including vitamin deficiencies as well, and diet again could cover most of the deficiencies, especially such as beriberi, which was seen in prisoners of war. Alcohol can cause peripheral neuropathy in many ways. It can affect the B group of vitamins, especially in chronic alcoholics, and there can be a direct effect of alcohol, nutritional, and even after chronic liver disease sets in. Systemic illness can also lead to peripheral neuropathy, or even the treatment of systemic illness if they're long-term antibiotics. For instance, some of the anti-tubercular treatments, especially INH, antibiotic called linezolid, all can lead to peripheral neuropathy. There's a vast list, and it would be good to go through these drugs and try and commit them to memory, as some of these can come as theory questions. Then, of course, there are connective tissue disorders. There's infections such as Lyme's disease and leprosy. And, of course, the paraneoplastic neuropathies are associated with cancer. They can be painful paresthesias, and they can only be a painful neuropathy, which is seen in nutritional, or can be seen in a condition called small fiber neuropathy, in which the reflexes are intact. It affects very small nerve fibers, but can be quite acutely painful. So the diagnosis is mainly clinical: distal weakness with loss of reflexes, with intact loss of reflexes, and of course, in the initial stages they may be intact muscle mass, but subsequently they can develop some wasting and they can develop trophic changes. So investigations includes a hemogram, a biochemical profile, but you would also look for more obscure conditions, especially vasculitis, connective tissue disorders, celiac disease, very common. It can cause neuropathy by direct effects as well as by nutritional effects. So one must screen for celiac, vitamin D levels, ACE to exclude sarcoidosis, ANA, ANCA for basically vasculitis, and other connective tissue disorder screens as well, and a paraneoplastic antibody screen. Usually we can do a CT of the thorax, abdomen, pelvis if we strongly suspect a paraneoplastic cause to further the investigations. In some conditions you might consider a nerve biopsy if you don't get a clear-cut diagnosis or you suspect some infiltrative disorder or infection such as Hansen's disease. Electrodiagnostic studies are finally confirmatory. They're usually done fairly early in the diagnostic process, and the main idea is to confirm the neuropathy and then see whether this has a pattern mainly of demyelinating or axonal, as your treatment modalities would depend on it. Now, axonal neuropathies are not generally treatable, but demyelinating neuropathies are immune mediated, so respond to steroids, IVIG, which could be one-off, or a pulsed IVIG and immune suppression. We also look at nutrition, nutritional supplements, investigate to exclude a cause, especially if you can find a treatable cause like a B12 deficiency, then we would supplement B12, and investigate sometimes further down if you find a cause, for instance, but we would investigate around it to see if there's any other correlated causes. Eliminate and treat the cause, especially if the patient has exposure to neurotoxins, then you remove them from the source of neurotoxins. Maintain good physical function. Rehab medicine plays a big role in this, and pain control we'll talk about in a bit. Now, acute neuropathies, generally one neuropathy that will spring to mind is the GB syndrome. There'll be a preceding illness, there'll be a prodrome, and then a sudden ascending weakness will develop, but suddenly patient goes off legs and is unable to weight bear, and is confined to bed, and the weakness spreads fairly rapidly, involves the lower limbs, moves its way upwards, and as you develop ascending weakness, you start losing your reflexes, and it can become generally areflexic. Arms get involved later, then occasionally the face, people can present with facial palsies as well. The bulbar muscles get involved, speech and swallow gets affected, and of course, if in acute, very acute situations, respiratory muscles can get affected, and the patient might even need intubation. There could be sensory complaints. It's supposed to be a pure motor syndrome, but you can have sensory complaints. You can develop autonomic features as well, especially tachycardia, and this can sometimes lead to low blood pressure due to inadequate filling of the ventricles, and can make you very unstable, and the patients have become seriously unwell as a result of autonomic involvement. The motor weakness persists and starts spontaneously improving in most cases, but some cases will have persistent weakness despite optimal treatment. The variable patterns to this, some people's illness will last just a week and they'll improve. Others may need intensive care for at least 2 or 3 weeks. If it persists more than 4 weeks, then we call it CIDP, chronic inflammatory demyelinating neuropathy, and the treatment is on similar lines with immune suppression, and generally it helps to get people to a decent quality of life. So how do we diagnose AIDP? We basically look clinically with someone with an ascending flaccid paralysis and weakness of limbs is very likely to have the GB syndrome. We try and do a lumbar puncture. If you do it too early, sometimes you may not pick up the albuminocytological dissociation, means the proteins are very raised, and this is because of demyelination and shedding of protein into the CSF, but the cells are not raised, so which goes against infection. In fact, if there's a large cell count, especially white cell count, then it's unlikely to be AIDP or GB syndrome. Electrodiagnostic studies are fairly classical in demyelinating neuropathies. The compound muscle action potential will be reduced, and so the area under the curve is reduced, and so their amplitude is reduced. They have prolonged distal latency. The conduction velocity likewise will be affected, and the F waves become absent. Differential diagnosis, we always check potassiums because hypokalemic paralysis can present in the same manner. We need to exclude transverse myelitis. Usually signs of myelitis are bladder involvement and upgoing planters, which would be unusual in a GB syndrome. Neurotoxins, shellfish and botulinum can also present in this way, as can tick bites, which can lead to a similar picture of flaccid body paresis. Treatment is with immunoglobulins as soon as possible. We would start the patient after obviously screening the patient, and then usually give it 2 weeks. If the patient improves, that's fine. Otherwise, we repeat it, of course. And then if there's no response further, we can try plasmapheresis. And then the patient obviously goes intense neurorehabilitation. Bell's palsy is described by a general practitioner by the name of Bell, and hence Bell's palsy. It's a spontaneous event, usually one-off, but people can get recurrent Bell's palsy, especially if they're immune compromised. It involves symmetrically one half of the face, starting from the forehead. You're unable to wrinkle, unable to close your eye, unable to blow out your cheeks, and there is a deviation of the angle of the mouth, and occasionally they can also develop inability to close the eye and tearing because of irritation to the cornea. And they can have hyperacusis, especially if the nerve to the stapedius which is a part of the facial nerve, gets affected, or there can be a loss of taste if it's proximal to the chorda tympani, which subserves taste from the anterior 2/3 of the tongue. They develop facial weakness. It's mainly a clinical diagnosis. You don't need electrodiagnostic studies to diagnose Bell's palsy. We generally put the patient on a course of steroids and taper it down over 2 to 3 weeks. If it's caught very early in the first week, patients are usually treated in this country with a course of antivirals, as there's a strong association of the herpes virus with this. Physiotherapy, care of the eyes, artificial tears, and of course, if the patient is left severely disabled after an attack of Bell's palsy, which is most unusual, then some form of plastic procedures where slings are put under the cheeks to lift up the facial muscles. Autonomic neuropathies are very rare, but they could be a part of the sensorimotor neuropathy. They could be individual as well, such as in diabetic neuropathy. The autonomic fibers are separate from the other fibers, and they subserve the autonomic nervous system, which tends to be autonomic, as the word suggests, and functions on its own, but flight and flight reflexes and many of the body functions are under the autonomic nervous system. So basically, it can present with autonomic dysfunction. There could be bladder symptoms of retention, overflow. There could be bowel symptoms, alternating diarrhea and constipation, abdominal pains, cramps. The heart rate can get affected, as is the blood pressure. The respiratory system with features of sleep apnea. The skin, either a dry skin or hyperhidrosis, and of course erectile dysfunction, all features of autonomic neuropathy. Neuritis is inflammation of the nerve, usually in a setting of infection. They can be very painful, the nerves in this condition, such as infection, diphtheria, herpes, Lyme's disease, leprosy. Lyme's disease is fairly common in people who go into the forest. Sticks are carried on wild animals and transfer themselves on to human beings. And generally there's a history of going for a trek through the forested areas, and patients presenting with Lyme's. Radiation, drugs, particularly chemotherapy, can produce neuritis and a painful neuropathy. Nutritional, as I mentioned before, peri-peri, and alcohol. Now, there's a condition called the brachial neuritis, which involves the brachial plexus. Can be secondary to, of course, injury, tumor, childbirth. Obstetrics, shoulder dystocias can cause brachial neuritis. Usually it will be one-sided, but it can also cause a bilateral involvement in an idiopathic condition called Parsonage-Turner syndrome. Symptoms can vary. The arm can be mildly affected and not weak, but occasionally you can have limp arms that hang by the side. Depends on the location, extent, and involvement. There are two paralysis that one should know about. One is Erb's palsy, seen in obstetric issues, and here the arm is limp, it's rotated medially, the forearm pronated, and this is usually as a result of instrumentation at the time of delivery. You have clump case paralysis, in which you can present with a clawed hand paralysis to forearm and hand, and the treatment is rehabilitation. So I've already talked about investigating peripheral neuropathy. We basically look for a treatable cause. If you can find it, then obviously we would treat. It may not reverse the neuropathy, but it certainly would prevent progression. Treatment of neuropathic pain is quite complex and can be very difficult. We use tricyclics, we use anti-epileptics, particularly carbamazepine. We use pregabalin or gabapentin. We use opioids in severe cases. Transcutaneous electrical stimulation with a TENS machine can be useful, and patients, of course, are sent for rehabilitation, particularly if they develop weakness of their limbs, to improve their strength, and of course balanced diet with all the nutrients, vitamins, etc. Is useful, and of course remove the source of toxin, which includes alcohol, and sometimes you got to get people to stop drinking so that the neuropathy gets sorted. Finally, a word about hereditary neuropathies. These are inherited. They're different age of development of symptoms over a period of time. If this comes in early as compared to the previous generation, the phenomenon is called anticipation. Hereditary sensory-motor neuropathies, there are total 7 of them. 1 and 2 are also called Charcot-Marie tooth, after the people who describe them. There's a very classical phenotype where there's a high arched foot with Pesceva's deformity, and sometimes they can get an empty inverted champagne bottle in their lower limbs or shape. There's also distal hereditary sensory distal hereditary motor neuropathy, or it can be a sensory autonomic neuropathy. Sometimes it can be a pure sensory neuropathy. Of course, these are always in accompanying other neuropathies. You can also have small fiber neuropathy, which is acutely painful because only small fibers are involved, and these cannot be tested by electrodiagnostic testing. And finally, there is a condition called hereditary neuropathy for tendency for pressure pulses. It's an autosomal dominant condition. The PMP22 gene is involved. They can have neuropathic pains, focal involvement of one nerve, or a generalized neuropathy, and usually they're self-limiting and recover, but certainly postures and positions which can put pressure on the nerves, such as sitting cross-legged, should be avoided. So this is it about peripheral neuropathies. This is just a brief overview. It's a complex topic. Series of textbooks have been written on it. But it'd be good to have a quick read through this, especially from any standard textbook, so that you know about the various forms and the various causes of neuropathy, and then can approach it from there. Thank you.